organize and lead the training. Thank you very much. And we are working towards making sure that we are able to provide you with the absolute best resources possible as we go through this Prevention Leaders Virtual Training Series. In a moment, I'll ask Dorothy Chaney to introduce or reintroduce. Some of you know her very, very, very well. She's a renowned national trainer and speaker, and we're grateful that she's a part of our team. And so we'll ask her to introduce herself. Go ahead, Dorothy. Why don't you go ahead and do that right now?
Thanks, Carlton. And good morning, everyone, and welcome. I'm really excited to be here today. A little bit about me. I am on the road a lot, but today I am actually home in Wisconsin. So it's not Mardi Gras here, and it's not very nice weather, but nonetheless, I dare to dream. So I've been working in prevention about 25 years. And my background is I've got an adult master's degree in adult education. And I was the state executive director for Mothers Against Drunk Driving. So I have an alcohol policy background, and I've been working in prevention and treatment or prevention and intervention for a very long time. And I've been working with Carlton for the last 4 or 5 years. And I also wear a hat as a national trainer with some other organizations. And in my own sort of part of the world, I also do a lot of work with public health departments. But one of the things that I'm really excited about this morning is having this conversation about harm reduction, because especially since the onset of the opioid epidemic, we've been talking about harm reduction, but we haven't really taken a minute to sort of define what it is. And so that's what we're going to do today, is we're going to have an opportunity to reflect on what harm reduction is. So I'm really excited about our conversation. Thanks, Carlton.
Yes. Thank you, Dorothy. Paul, I'm going to turn it over to you as I'm helping someone who's trying to get on. Okay, go right ahead.
Thank you. Good morning. I will give the floor to Dr. Tobert because I can see she's right here. Yes.
Good morning, everyone. Thank you all for joining us for our second series. I am Dr. Tobert, the Executive Director of the Louisiana Center for Prevention Resource. And this is a place where you all get your trainings. And so we offer a lot of training. So I do want to say thank you to the Office of Behavioral Health with our program manager, Ms. Felicia Johnson, but also to Dr. Leslie Freeman, who I believe is on as well. But we do have another training series coming up to round this off, and hopefully you all will join us for that as well. So thank you all so much.
Thank you, Dr. Tolbert. Paula, do you have other instructions for everyone at this time?
Yes, I do. Please sign up on the chat room, your name and your organization. We're going to need that information in order to issue your CEUs. So make sure that you sign in the chat room.
Fantastic, fantastic. Well, welcome again, everybody, and we're going to go ahead and get started.
Oh.
There you go. We're going to go ahead and get started. Thank you guys for enduring the technical aspects as we're working through this. And I am excited about the training that we have for you today. Dorothy, if you don't mind, if you can stop sharing your screen for just a moment. Thank you very much. And I'll share mine. Hold on one second. And as we mentioned, we are here today to discuss just kind of the ways in which prevention professionals ought to be thinking about and considering harm reduction. We've had this growing conversation, a necessary growing conversation about the importance of harm reduction and harm reduction strategies, and really its relationship and role with prevention. As our field has become more and more a part of understanding the nature of this role in this relationship, it is important for us to understand kind of what does it mean for us and how can we apply it to our own prevention efforts. And so, as a way of discussing this, I'm so extraordinarily grateful to have my friend and my colleague and my partner in this endeavor, Dorothy Chaney. It is a pleasure and honor to work with Dr. Tolbert and Paula and Dr. Harrison and Dr. Rahal and Felicia Johnson and everyone there in the state of Louisiana. And I'm so grateful for the wonderful and remarkable relationship that we have with each and every one of you. We are in all of the efforts that you are applying. We are looking forward to seeing how we might be able to help support those efforts moving forward. In the context of this conversation, though, I want to share with you a couple of things, a couple of items, right? This training has been designed to speak exclusively and specifically to you as a state. So we're going to have, we're hoping that you bring some of your personal understanding and expertise and experience to the conversation. So this is not about Dorothy and I didactically sharing with you and to you, kind of in a lecture format. This is more about a conversation that we hope to have and enjoy with you so that we all might be able to learn with and from each other. But more importantly, part of the reason and part of the rationale for this conversation is that we have to understand as we are looking at how we might be able to mitigate the harms associated with substance use and misuse within our communities, that there is a wide range of using patterns, right? And the notion is that in any given population that we are working with, right, you will find everyone and every kind of individual within the context of that population. Everyone from those that are steadfastly non-users, right? Just they are abstainers, and have made that choice, made that selection for themselves for a variety of reasons that they might have, to those that are more vulnerable because of genetics, because of environment, because of historical aspects with respect to their family or others, to those who are those that may have initiated use and experimented with respect to that, but may have discontinued that use over time, all the way throughout to those who have moved toward the continuum that means that they
I don't want to say I don't say yeah.
with respect to everything. And so with such a wide range of substance use patterns, it is important for us in prevention to understand the very, very necessary aspect of knowing that that requires a wide range of interventions as well, right? This is no one size fits all kind of approach that we have to apply in prevention efforts if we're going to be as effective as possible. And so that is why I am extraordinarily excited about the conversation that we're going to have today. And so a few things that we want to make sure that we get out of this conversation today. First and foremost, we want to make sure that we are able to have an open and a safe discussion about what it means to think about harm reduction in relationship to our work and how and why we need to understand it. Secondly, we want to make sure that we're looking at this from our profession and thinking about how we might be able to support each other as we advance our understanding with and for those that we are working with in this field. And lastly, we're inviting you to challenge yourself, right? Challenge yourself to kind of move beyond kind of what may feel comfortable, to be able to accept that there are some important areas that we need to expand the lexicon of our vocabulary, that we need to be able to expand on our own understanding with respect to the work that we're doing. And to help lead us in that conversation, I'm inviting my friend Dorothy, who has done some extraordinary work helping lead communities and coalitions and helping them think through these as we're going forward. And so, Dorothy, I'm going to help a couple of folks who are trying to get on I'm going to
Perfect.
pass the mic over to you.
Awesome. So thank you. Before I bring the slides up, I just sort of want to set the stage in my head. First of all, I'm not a harm reduction expert. I'm a preventionist. And I've had the opportunity to work with every state and many countries. And I have the term harm reduction has sort of come into our vocabulary. And a couple of years ago, I was asked to actually lead a discussion on harm reduction. And so I realized something. I never really took a moment to learn what harm reduction is. What we use this term, but what really is harm reduction? And when I started learning about harm reduction, I realized that harm reduction and my attitudes and beliefs were really sort of inextricably mixed. So I gave myself the latitude to sort of put my attitudes on the shelf and really just seek first to understand what harm reduction is. And then secondly, to really identify my own actions and my own attitudes. And thirdly, how as a person who works in prevention, able to, what is our role in advancing harm reduction principles, and how do we sort of, how does that fit in our world? And so I'm not an expert, but I'm a lifelong learner. And I've had the opportunity to have this conversation. And I do have expertise in this field. I just am not a harm reduction person. I'm a preventionist. And I can tell you every time that I've had this conversation, it's been a journey. It's been a journey of discussion and discovery, and people are sharing. And so when Carlton says this is not meant to be didactic, indeed it is not. It's really an opportunity for us to all explore the concepts of harm reduction, and then to sort of draw some ideas around how it can inform our actions and our work. And so there's a couple of ways that you can share. First of all, visual cues are just sort of lost on Zoom. And although there's Carlton and I, please at any point just say, hey, Dorothy, and I will invite you to contribute to the conversation. We will also keep an eye on the chat box. And so you can definitely do conversation and comments there. The other thing I'll say, though, is you can do a private message to either Carlton or me. And especially when we're having sensitive discussions or discussions about, issues such as this, harm reduction, sometimes people want to contribute, but they don't really want to have their name. So if you make a confidential private chat comment to Carlton and I, we'll read out and say, oh, a really great comment came, but we won't say Carlton said.
What does this mean as far as,
So we want to make sure that you
all
have
these tributaries?
opportunities to share. So as we go through this conversation, I just want to share, I want to start by sharing, I have a mentor in harm reduction work, and his name is Patrick Riley, and he works in street outreach in the very urban part of Milwaukee. And so when I first started trying to learn about harm reduction, my first call was to Patrick, because we've got deep respect for each other. And Patrick said, denying people access to harm reduction services is telling them that your opinion is worth more than their health and life. And I thought that's just a great way to sort of start the conversation, is how are our opinions sort of shaping harm reduction in the community and how that's impacting people. I also love this, and I think this is a great way to start. This came from one of the great philosophers of our time, Jerry Seinfeld. And so he says, there are many things you can point to as proof that the human is not smart. But my personal favorite would have to be that we needed to invent the helmet. What was happening, apparently, was that we were involved in a lot of activities that were cracking our heads. We chose not to avoid doing those activities, but instead to come up with some sort of device to help us enjoy our head-cracking lifestyle. So Carlton, harm reduction, we've got that down, right? That's a beautiful example of harm reduction. And it kind of was good to set the stage. It doesn't mean that we're going to stop the behavior. We're going to try to reduce harm in doing that. So harm reduction is not just, in substance use, but really we do behaviors that we try to mitigate harm. And that's really what harm reduction is. Let's start with answering the question, though, of why people use drugs. Thoughts. We'd love to hear in the chat box or unmute. Why do people use drugs or substances? Why do people use drugs or substances?
Either put it in chat or raise your hand if you would like, if you don't mind coming on camera with us.
Depression. Yes, Tamara, yes, depression. People use it because they've got depression or anxiety or mental health issues for sure. And they're self-medicating or they're using it to cope with emotional stress. Yeah. Why else? A lot of times people are using it for as a coping mechanism or to feel well. I love that one too. Yeah, to feel well, to hide pain or to mask pain, whether that be emotional or whether that be physical. Trauma, a huge contributing factor to using drugs is trauma. They see others around them using, there's family norms, they're doing it recreationally, they're doing it to fit in. All of the above, absolutely. There's so many peer pressure or favorable youth attitudes, absolutely, because others around them are doing it. It's happening with their peer group. Hazel, yeah, they're reducing stress in their lives and they can't cope and they just can't deal with their problems. So here's the thing. Starting this conversation about harm reduction, we need to understand that there's so many reasons why people actually use substances. And it helps people feel better in the moment. It helps them manage pain. You guys mentioned all of this. Here's the other one is, it may be more accessible or cheaper compared with prescribed drugs. And Carlton, I was working in New Jersey a few years ago.
Yeah.
And we talked with a really urban community and they described it as community doctoring. That in some communities with low socioeconomics, people don't have access to healthcare, whether it be transportation or whether it be medical insurance or whatever the factor is, but they have a close peer group or community group. And so well-intentioned neighbors are saying, oh, Carlton, that sounds like the same cough that I had. Here, take this cough medicine with codeine in it.
Yeah.
And so that often can lead to misuse, but there's so many reasons why people use substances. And it can either help us feel more connected, like some of you identified, or it can help us sort of escape or feel disconnected. Hazel, you said, yes, I see this all the time with my clients that come to me. I would love to hear more about that, I would love to hear more about that if you would like to share.
Hazel, do you mind coming off mute?
Yes, I deal with the courts, and
Mhm.
also I deal in with prisons.
Yeah.
And also with low income individuals that are seeking with jobs or have lost homes or have lost loved ones, and they are trying to cope because they don't have, like you say, they don't have the money to seek out. And sometimes in different races, they are taught that, that's the only way. And I think it might sound kind of crazy, but that's the only way because they don't want to seek out a psychiatrist or anyone else or someone that could help them because they're ashamed, because they're supposed to be a strong individual, or they may be the breadwinner, and or they don't have anyone that they can support system. They don't have anyone that they can talk to. So they lean to those accessible drugs, maybe on the streets or someone that they know.
Yep.
Or sometimes they, like you say, over medicate themselves with prescription drugs.
Thank you so much for sharing. And so as I was starting to look at harm reduction, like I love to hear this because we need to understand there's a lot of pathways into people using substances, and there's a lot of reasons. It's not that they're just one day deciding to make bad choices and start to use drugs, that there are a lot of really sort of legitimate pathways into people trying to seek whatever it is, trying to seek care or connection or to feel healthy, or a sick person trying to get well. And so one of the things that seems to be sort of prevalent is there tends to still be, even though we've been working in this field a long time, judgment around people who use substances. But we need to understand that there's so many pathways into substances. It's not just people making bad choices and then becoming dependent. But, and you guys mentioned all of these, there's co-occurring disorders. And, the other thing, at some point, and we see this with many substances, at some point, it's not a choice anymore. People become sick if they stop using, so they're physically dependent. And now they're trying to use to stave off withdrawal. And they may not have access to other options like we talked about. So there's so many different ways that we can come to using drugs. And for me, that was the very first piece of learning about harm reduction is, why do people use drugs? Why do people start using substances? And so there's a lot of reasons. And then my next question was, let's take a minute to really look at what is harm reduction. Now, I'm going to define it, but I'm going to ask you, what is harm reduction? How do you define harm reduction? Or when you think of harm reduction in your mind, or if you work in harm reduction, how do you define it?
Go ahead and put that in the chat, or if there's somebody that's willing to raise their hand and offer a definition for us, please do so, and we'll take you off mute. What is harm reduction to you?
Usually there's just a little bit of a delay. I can tell you, I didn't know how to define harm reduction, but I kept using the term without really knowing what it was. I just knew that we started using it in our field, especially around the time that the opioid epidemic came on strong. So how do you define harm reduction? Would love to hear. Carlton, I'm going to ask you. How do you define harm reduction?
It's really interesting, right? So as you mentioned, when, for years in this field, we never even heard of the conversation or heard of the term in a great many ways. And if we did, it was about folks that were kind of over there in that part, and it had nothing to do with us. And so everything from needle exchanges to safe using environments and the like was part of what it is that I thought it meant, right? But come to understand and come to know and understand that is actually an approach. It's an approach to thinking and looking and working with folks to see how we might be able to minimize and mitigate deaths that are occurring and minimize the harm that's associated with that use. And so I'm really interested in what folks are saying. Jose, so we have to minimize harm and risk, of course, right?
Love it, yeah.
Jose is saying, meeting people where they're at, utilizing compassion and person-centered approaches towards improving overall wellness and functional levels. Fantastic. Reducing the negative social and physical experiences that occurs with behaviors. Jose, would you mind coming off mute and kind of expanding a bit on what it is that you shared in the chat, please?
Yeah, just like so utilizing compassion, kindness, and communicating and providing a safe space for keeping the conversation open and improve the overall wellness, and also like from all the different dimensions of wellness, right? In that way, we can use person-centered approaches and use compassion and kindness when we and try to help and guide their lives to improve the functional levels of people who use drugs.
Yeah. Jose,
thank you.
I love that. And Jose, you are way smarter than me. I'll tell you, when I first started learning about harm reduction, and I'm a displaced Canadian, I'm American, but I'm still a proud Canadian. And in Canada, we had supervised injection sites for a period of time. And I had the opportunity to go to one called Insight in Vancouver. And that's in British Columbia. And so it's simply that. It felt very clinical. It was a supervised injection site. And I've always thought about harm reduction as really about very pragmatically reducing death, reducing overdose. But what I didn't know is what you explained, Jose. At the heart of harm reduction is compassion. It's compassion and ensuring dignity. And so one of the things that I had to do as a preventionist, as a human on this planet that doesn't use substances, is really try to seek to understand the philosophy of harm reduction, because at the heart of harm reduction, there's that pragmatic piece, but it really is about love and compassion. And that's what I want us to think about today, is look at how can we really employ harm reduction strategies, but understand that it's more than just syringe exchanges. It's more than just Narcan. It's more than just reducing harm. It's about respecting and appreciating and being compassionate to every human being, even those who are making choices or that are living a lifestyle that we can't relate to, and that we may have judgment over. And so, and we may not want to admit that, but we all have our own mental models too that we've seen, right? And so that's what harm reduction is. SAMHSA defines harm reduction as an approach that emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, to improve the physical, mental, and social well-being of those served. And then the last piece is to offer low threshold options for accessing substance use disorder treatment and other healthcare services. And so this is SAMHSA's definition. But as I really got into harm reduction, I started to really understand that it's this, but it's also just meeting people where they are, even if they're choosing not to get into treatment. And that's what really sort of blew my mind, is I always thought harm reduction was a means to getting people into treatment. But true harm reduction philosophy is, we're meeting you where you are to give you what you need now to be healthy and safe, without any expectation that you're going to do anything else that we want you to do. You have dominion over your own life and over your own situation. And so I really started to explore this further. So harm reduction understands drug use as a really complex, multifaceted phenomenon that encompasses, a continuum of behaviors, from total abstinence to severe and chaotic use, not my term, and acknowledges that some ways of using drugs are safer than others. And harm reduction also embraces the concept that abstinence may not be the ultimate goal for people who are using substances. And that, again, for me as a preventionist, was something that I really had to learn to wrap my head around when I'm really understanding the theory and the philosophy of harm reduction. So there was a comment that came in that said, to have a conversation with the justice system on how we can help deal or understand harm reduction, because it's very different from prevention. It's very, but we're all connected, right? We're all, and we have a role to play. I love that. Thank you for that comment. So here's that continuum of drug use. From no use, never picked it up. I have a 92-year-old mother that's never had a drop of alcohol in her life. So from no use to chaotic, that your life is really rotating around or revolving around your use, and it has significant impact on your life and your health. But the reality is, harm reduction can happen here with binge drinkers. It can happen here with situational users or with habitual or daily users. Harm reduction can happen on that continuum. I think sometimes we think right to sort of the end of the spectrum, that there are people who are unhoused and they're, injecting on the streets. Well, the reality is that's part of harm reduction, but it's so much more than that. So let's take a look at the harm reduction and the continuum of care. And I'm sure we're all, as professionals, familiar with the continuum of care. So I'm going to ask folks in the chat box, just as I'm going through this, if you could say in the chat box, what part of the continuum that you work on? Do you work in prevention? Do you work in treatment? Do you work in recovery? Because we all have a perspective to share as we go through this. So I'd love to see where everyone's working. I know there's some preventionists, many preventionists, prevention. So my people, see, this is why this is an important conversation, because we don't necessarily work over there in harm reduction, or do we? Jose, you work from prevention to harm reduction. Where there's gaps. Hazel, all three. Love it. Yeah. And really, the continuum of care really is a beautiful way of looking at collective impact, that we all have a role to play across the continuum. So this 90-degree angle here that separates prevention from treatment is intervention or case diagnosis or case identification. And so when we think about harm reduction, we start to really think about post-intervention or post-diagnosis. So we can think about things like syringe exchange programs or education programs on safe use, or naloxone training and distribution, or reducing harm through the advocacy of medications for opioid use disorder or medicated assisted therapies. Those are examples of harm reduction strategies post-diagnosis. What are some other examples of harm reduction strategies that you can think of that happen once a person has been diagnosed? So with persons who have an active substance use disorder, there's syringe exchange, there's naloxone. We'd love to hear from folks how you're working in harm reduction or some other examples post-diagnosis. Peer support programs. Yes, 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 absolutely. Other thoughts? Would love to hear you unmute or put in the chat box. And you know what's really interesting? A few years ago, I was doing a conference, a national conference, and was doing a session for probably 150 or 200 prevention professionals. And I asked how many people, and this was a few years ago, I said, how many people worked in harm reduction 5 years ago? And maybe 1 or 2 people put their hand up. And then I said, how many people are working in harm reduction now? And almost the entire room of preventionists raised their hand. And it was so interesting because especially with the onset of the opioid epidemic, we as preventionists have been really moved into working on things like distribution of Narcan, of educating related to the importance of Narcan or training for Narcan. And it's really been out of our wheelhouse because they're traditionally post-diagnosis or for folks, a group that we haven't really been working for or with. But there are examples of harm reduction strategies that do fit in to the work that we do. So think about those kids that are caught drinking at prom, or the kids that are vaping in the bathroom, or I don't know in your community, but I have found this in so many communities. It's surprising to me that there are older adults who are developing substance use disorders later in life because they're unintentionally mixing alcohol with their prescription medications. And specifically, I've uncovered many, many assisted living facilities all around the country that have happy hours for the older adults. And so the older adults will go to happy hour and then they'll go to their room. They're not worried about driving. It was a social hour. There's alcohol served. It was, a mixer. And then they go back to their room and they take the Vicodin or their Ambien or whatever there is that they've been prescribed. And so we see a whole sort of cohort of older adults who are developing substance use disorder because they're unintentionally mixing those medications and it's really unsafe. That's harm reduction and trying to address that to prevent the onset of a diagnosable substance use disorder. And many states now have standing orders of naloxone so that we can advocate for the co-prescribing of naloxone with any prescription of an opioid, which doesn't require somebody to have been diagnosed with an opioid use disorder. It could be somebody on their very first time using opioids for a surgery, for example, but that co-prescribing, that's harm reduction. So can you guys think of any other harm reduction that falls into that indicated prevention that you work in? And if you'd like to unmute, I would love to hear from you. Anybody in prevention work on vaping nicotine cessation programs in your work?
Okay, so we are Office of Public Health here in Region 4 in Louisiana. We have a presentation. So yeah, so we are in outreach, prevention, and education, and we have a dangers of counterfeit pills presentation that we do in middle schools and high schools. And we also include the dangers of vaping because we have found, and I have heard this from people in rural Louisiana, small towns, that there's people pressing vapes like locally. It's not just like the
Ah,
vapes that you buy. There's people buying the cartridges to refill them and press the vapes and sell them as a legitimate vape. So there has been evidence of some of those nicotine cartridges being contaminated with fentanyl as well.
mhm,
So we
mhm.
do talk to the middle schools and high schools, and sometimes when we go there, I even emphasize to the kids, I said, look, usually I've been having this conversation with 12th graders only, but unfortunately, it has come to a point that vapes are in the middle schools as well. And I have a middle schooler, and she tells me when I go to the restroom, it
Yeah.
stinks like vapes because
Uh-huh.
it smells like so potent, and it's like it stays in there. So even though it's not cigarettes smoke, is the smell from the vapes that gets in the room as well.
Yeah.
So we do talk to them about that and about the how it affects the brain, and brain is still developing, and how it affects the lungs, and also is Heart Month, right, for the American
Yeah.
Heart Association.
Yeah.
So we also talk to them about how it affects mainly the brain, the lungs, and the heart. And this harm reduction is part of our overdose prevention and also education that we do.
Love
with
it.
the
And
public health.
those are examples of harm reduction. We do. Thank you so much, Jose. Sounds like you're doing some amazing work too.
We're
And,
trying, we try to stay busy out there.
and sounds like you're being really effective. We work in harm reduction when we're working with that indicated population of youth that are already vaping or they're already, and we're really talking about, one pill can kill. Really, we're talking about harm reduction because we understand that youth are using, we're trying to educate them to use in a way that's going to be, safer. Although, of course, when we're looking at prevention, we want abstinence. But the reality is in that indicated population, there are youth that are already using. And so we work and we see that youth in so many communities, youth are trying now to quit vaping. That's harm reduction. They may not have a diagnosis, but they've got problematic use. That's harm reduction. It's to reduce the harm. It's to reduce the likelihood that they will then develop a diagnosis. And so we do work in harm reduction. Harm reduction really happens all the way along the continuum. Over here in recovery, we work to prevent relapse. That's harm reduction. So harm reduction really happens along the continuum of care. So thank you, Jose, and thanks others. So harm reduction is public health. So think about opioid treatment programs or harm reduction, incarceration programs. And I know there's someone that works in the jails. That's harm reduction. Overdose response teams, and that could be peer support. That's harm reduction. Narcan training. So many of us that are working in prevention are still working in Narcan distribution and trainings. Fentanyl test strips, that's harm reduction. Although it's really interesting because in some states, and I'm not sure, I would love to hear what it is in Louisiana, are fentanyl test strips legal or are they considered paraphernalia? Because in some states, they're considered paraphernalia and not recognized as a harm reduction strategy.
So I don't know if somebody else wants to pinch in, but I can share about that.
Yeah.
So as part of the Overdose Data to Action grant, I am doing outreach in the community. And the two main things that we do is opioid education or overdose prevention, right?
Yep.
And Narcan distribution. But we also get through a Louisiana hub, it's a health hub that we have, we get fentanyl test strips as well. So as Office of Public Health, we're distributing those in our health units, where they see people, no matter income levels, or no matter what kind of insurance they have or inability to pay. We don't turn anybody away for inability to pay. So I am distributing fentanyl test strips, and they give it out to the community, no questions asked. That's what I like to say. And sometimes I go to the outreach, like faith-based organizations, and we do, for example, Christmas Without Walls, and it's literally directly to the homeless people. You see people that are like experiencing withdrawals from whatever they took the night before, passing in front of us, trying to just grab all the goodies, a sanitizer, whatever it is. But the ones that come in and they really want to try to learn a little bit, well, we have people taking blood pressure over there. We have people taking vitals, anything that they can do. So it's a whole collaborative approach. And I put 6 fentanyl test strips that I have left just because, and the amount of people that were interested about it, it was tremendous. Like, hey, I have that issue. Can I have one of those? And when I had a nursing student holding the last one, she's like, here you go, sir. And she gave it to me. And I said, I'll get back to you. So it was quite interesting to know that there's a lot of people that are interested to know about it. And just like they say, just test it. You know, if you happen to resource to something that you're gonna find out there in the community, then perhaps you might want to test it before you take it. So we are doing a little bit of distribution of fentanyl test strips in this area.
Great. And again, that is a prime example of harm reduction. Of course, people are welcome to then ask for resources and services, but if what they need is a fentanyl test strip so that they can use more safely, that's an example of harm reduction. And it's not without politics, right? Because when I said in some states it's considered, yes, amazing work, Jose. In some states, the fact that it's considered paraphernalia speaks volumes about the philosophy or the acceptance of harm reduction as public health. And Jose, you're walking the walk and you're describing these are public health interventions that are related to reduce harm. Love it. And Donna, yes, amazing work. Carlton.
Yes, and again, I want to add my thanks to Jose for your local expertise and providing that to the conversation. But I want to speak more importantly about the fact that this is the reason why this training and this conversation is so vitally important for us. There's a range of opinions when you mention the term harm reduction, and particularly with respect to our field. And very respected members of our field who have varied opinions that are brought up when you speak about harm reduction. And so it's important for us to really be able to understand the relationship of harm reduction to our goal of public health, and how it can be framed and understood in a way that does not suggest that we're trying to promote illegal and misuse and perpetuate a problematic behavior, but to understand that it is important to meet folks where they are, to be able to move them towards our ultimate goal of sobriety. That's what it is that we're hoping for.
I love it. Thank you, Jose, and thank you, Carlton. And so this is a perfect segue because as I was really starting to understand, I know what it is, but like Jose said, at the heart of it is compassion, is there are actually key principles of harm reduction. And so I want to go through those. And I also want to challenge us because we're going to see as we go through these principles that they may not reflect our mental model of what harm reduction is. So the 6 principles are health and dignity, participant-centered services, just like Carlton mentioned, participant involvement and autonomy, and then understanding, just like the folks that said trauma, that there are sociocultural factors. Health equity and health disparities are at the heart of this issue, but there's also pragmatism and realism. And so think about your own practice wherever you are on the continuum and think about these principles. So first of all, health and dignity. Language matters. And we as a field have started to change our language, and we need to keep doing it because every time I heard the word addict, every time I heard the word junkie, you know what? I've gone to coalition meetings where really well-intentioned community members have been there, and there's someone from the recovery community. And that well-intentioned coalition member named Dorothy keeps saying, I'm so glad that we've got somebody with addiction. I'm so glad there's addicts at the table. And every time I hear that sort of that language that is just so nails on a chalkboard, I see that person in recovery sort of shrinking. Like every time that word, those words are language matters. And at the heart of this is understanding that harm reduction means that we are going to use person first language, that we are going to take the labels off people. Also, that we're going to interact with people in a non-judgmental manner, And I like to think that I'm pretty non-judgmental, but I took a hard look and said, what are my attitudes and beliefs related to people that are active drug users? And here's one thing, that I'm a mom. I'm a mom, and one of my daughter, who she's a senior, her mother had surgery and started using opioids. We know the story, right? And she then started using heroin and is now incarcerated. And one of the things that sort of went through my mind as I'm thinking about harm reduction is I'm angry with her because she left her child, who's a senior, now to not have her mom as she's going through all of the celebrations of being a senior, all of the things that I'm able to do with my daughter. And I had to understand, I need to interact with that family and with this woman as a mom and not judge, because we started the conversation with, there are so many different pathways into using. And really part of understanding and embracing harm reduction is looking at our own attitudes and beliefs. And it's difficult for me to say that I kind of judged her, but in my head, I was. And when I think about harm reduction, I think about, do we judge? What do we think? And then do those attitudes and opinions somehow inform our actions or words? But being person-centered and understanding that they know what's best for them and that we want to look at them without judgment. Also at the heart of harm reduction is involving the person in their own way, understanding that they know what's going to work best for them. So we know this on the prevention side as community organizers, nothing about us without us. It's the same when we think about harm reduction is, you know, as we're identifying where to do naloxone trainings or Narcan trainings, are we interacting with folks who are active users to say, how do we best reach the folks that need the Narcan? You know, are we training the middle-class moms who want it in their purse to be responsible adults? That's great. But are we also involving the participants and going where it's needed most by listening and being responsive and involving them in the development of our programs and services, or understanding that it's important to have nothing about them without them? Here's the one, Carlton, that really got me.
Yeah.
Is ultimately, and you even said it earlier, our mental model is harm reduction is to keep them safe till they get into treatment, to keep them safe till they achieve sobriety. The more that I get into understanding harm reduction, that's not the harm reduction. The philosophy is people will change when or if they're ready. And it was so interesting when I went to Insight in Vancouver, there are people who consider themselves to be in recovery, who are regular users of heroin, and they go into that supervised injection site. In their autonomy, they consider themselves to be in recovery. And so it goes back to that non-judgment, but also to understand that recovery is how they define it. And so they may be ready at some point, or they may not be ready to be abstinent. They're going to know best what's going to fit their own lives. And that to me was a really challenging one to wrap my head around, is that the end goal may not be the same goal that I have for that person. They may have their own goal based on the fact that they're autonomous adults. The other one is, this is the second last one, is equity. Is that we have to understand there are many roads to using substances. Let's go back to that community doctoring piece, where what that road or pathway into using was based on the health disparity of access to healthcare, or the health disparity of the socioeconomics. And so making sure that as we are really understanding harm reduction, that we understand that none of this is without connection to the social determinants or the social drivers of health, and that equity is at the heart of this. And we have to understand historical trauma. We have to understand violence and incarceration and all of the factors that lead to that. And so that's a really important piece of harm reduction as well, is understanding that people's choices may not actually be choices because of their social drivers, or where they are in their situation and where they've grown up, or where they're positioned. The last one is, I mean, this one is, I get it. This one is, it's practical. we want to make sure that we give people tools so that they are going to reduce harm. And that's sort of what we think of is we're not going to try to minimize, we're not going to try to ignore the harm. We're going to meet you where you are and say, we know that there are risks involved in injecting heroin, for example. What do you need so that you can do it most safely? And that could be, do you need the fentanyl test strips? Do you need the Narcan? Can you do it with a buddy? Can you do it in a way that you're not going to be alone when you use? Those are all sort of pragmatic and realistic ways that we can support people in harm reduction, in making sure that we're reducing the amount of harm. And so those are the harm reduction principles. Now, one thing I'm going to say, Carlton, really quickly is I would suggest that people do their own sort of research on harm reduction, because the journey for me was just so important. So I went through those harm reduction principles. What stands out to you in what we just went through? I'd love to hear from someone on those principles.
Beautiful. You and I were thinking on the same wavelength. Really want to hear from you with respect to kind of what your feelings are about these principles. Which one stands out for you? What's your relationship with any of them? And I think what I'd like to do is I think I'd like to play a little a frisbee toss, if you don't mind, with respect to this. And so I'm going to ask, if you don't mind, I'm going to ask one of you to kind of share some things. If you don't mind, Dale, are you there, sir? Are you there, sir? Can you come
Yes,
on?
I'm here.
Come on mute.
I'm here. Yes.
Fantastic. Can you just offer any thought that you might have with respect to any of these principles? Just choose one. What comes to mind for you, sir?
I think the principle that incorporated the equity piece and the understanding of what equity is, how more resources need to be given to certain populations, and it's not equal across the board. And
Right.
so I think that's an important piece that goes in so many areas, but particularly in prevention, just highlighting that equity piece.
I think it's extraordinary. Thank you, my friend. Thank you.
Hmm.
Hazel, can I toss the frisbee to you, please? Hazel, are you available, and can you come off mute? You may or may not be able to do that. Can I have a volunteer that would be able to come off mute for me?
Carlton,
Hey, Dr. Harrison.
how are you?
Wonderful.
Okay, I had an experience yesterday with a community resident, about 30 years old, experienced suicidal ideation, incarcerated just for about 30 days or something. But yesterday he just came to talk, and he was telling me he's on 4 medications. So then it was a beautiful day here in Louisiana, and we have a walking trail. So I was trying to encourage him to walk, but as I was talking, I stopped because I realized that he just wasn't there. Like his depression didn't even or either the medication did not even permit him the courage to just walk in the park.
Wow. Wow. Incredible. Incredible.
What I love about that is that, I mean, that's one of those principles, is meeting people where they are and respecting that they're going to do what's best for them. That's incredible. Thank you so much for sharing, Dr. Harrison.
And I'm going to go to one more if I could, with respect to this. And I'm going to ask Mike, can I come to you? Are you available, sir? Can I ask you to come off mute?
I am off mute, I think.
Yeah, thank you so much. Can you just simply offer, with respect to the principles, and as Dorothy's mentioned them, one main idea that at least struck you while she was having the conversation that you think is relevant and important for this conversation?
I think that, the main thing is the participant-centered services are, I want to add to that is that, that's what we tend to have to focus on, where sometimes we lose focus, especially with harm reduction.
Yep.
We have to maintain that focus if it's truly going to be harm reduction.
Absolutely.
Agree with you 100%, 1000%. And folks, thank you all. Thank all of you. We can give them like an emoji. We can do a clap for them. We can do whatever. Thank you all for participating in this. One of the main reasons why we want to have this conversation is that we're really hoping that we might be able to stretch a little bit. We need to be able to stretch as we're having conversations about this topic that is relatively new to the prevention workforce. It really is. And so we all are having to kind of work with and understand this a bit more. And so really wonderful to have wonderful guides like Jose that can help us to in our work and in our approach. But we have to become much more familiar with this. And so I'm really interested. These principles, some of them were really enlightening for me.
Thank you, Carl. They were for me too. It was really a journey. It is a journey for me to really understand and step out of my own sort of mental models and worldviews to really understand. And I think the one thing that the principles challenged me to do, and again, like I feel like I'm showing y'all my closet, like I'm bearing my soul, and I don't want you to see my closet, is I recognized as I was going through these motions, Mike, exactly what you said, is I was doing things to people. Like I wasn't recognizing active substance users as people. I was recognizing it as a problem. And people who are active substance users, if we look at them with love and compassion, and we understand that they still have autonomy over their own decisions, I started to look at my own attitudes and see I need to look at active users as humans who have as much dignity and right to services as I do as someone who's a non-user. And to me, that really was a huge awakening, that I've been going through the motions thinking that I'm non-judgmental. But when I really started looking at it, I was like, what are my attitudes and beliefs to those people that are using actively, or that there's harm in their own lives or in their families' lives because of their use? And it was a long, hard look. And that's why I consider this harm reduction really to be a journey.
Agreed.
So I want to talk about, so first of all, Carlton knows I'm an animal lover. They haven't barked today, but I've got 4 dogs right at my feet. So I can't do a slide without an animal, but let's also now talk about the elephant in the room. Donna said, for myself, I need to step out of my comfort zone and have the understanding that that's it. Donna, that's it, is that we need to step outside ourselves for a minute, put our sort of attitudes and preventionists on the shelf, and start thinking of, let's just give ourselves a minute to really think about what harm reduction is and the philosophy behind it. I love that. But the last piece I want to think about, and this is, I think, when I'm thinking about us as preventionists or where we work on the continuum, the elephant in the room, folks, is stigma. Because stigma is probably the biggest barrier to us being able to, as a field, truly embrace harm reduction as public health. Just think about, so thankfully in Louisiana, you're able to distribute fentanyl strips. In some states, in some communities, you're not. I still hear from law enforcement. I would be so interested if any of you do. I thought this was an old belief. I still hear it from law enforcement. Well, I don't carry insulin for diabetics, so why on earth would I carry Narcan for people that are choosing to use drugs and overdose? You know what that is? That's stigma come to life in actions. And it's preventing us from employing public health because of people's stigma.
Right, and I'm with you in that part. Uniformed personnel is uniformed personnel is one of our main goals to distribute Narcan around the region. So in Region 4, where I'm at here in Louisiana, we cover 7 parishes. That includes, we're in the South, okay? So it includes a lot of rural areas. So imagine this really quick. A volunteer fire department with minimal medical training. You think they want to get the Narcan back in the day with a syringe from that, and they have to inject it to the
Yeah.
person that's already suffering?
Yeah.
They didn't want to do that. No, so they were really kind of reluctant and hesitant to even receive Narcan, because we're not first responders. We don't really do that. But nowadays we get the calls and we're like, hey, Jose, can we get please some Narcan at our police department? Because we have to wait 15 minutes now for the fire department to bring the ones that they carry. And if I can, I will save a life of a young guy because I don't want to let him die. So that was great. So this guy started doing research on how do I get certified on Narcan? And I said, sir, I got you. Let me certify you. Tilt head back, press it. That's it. No more injection. All right, you're certified. Go for it.
That's it.
He was really happy because I did a little bit of like what we call informal training, right? I
Yes.
sometimes bring all the goodies and I do the formal training. I talk a little bit with the presentation and all that, but sometimes it's like, okay, guys, in and out. This shift fire department is coming in, so y'all clocking out, and this shift is coming in to work on the night shift. Okay, let's do this. So how many I got? More than 10? 14. Sounds good. Pay attention. This is easy to use. Don't test it. Keep it in the thing. Put 2 in the unit because you might need more than 1 dose per nostril to revive somebody. So if you have any questions, let me know. Once you run low, I can refill you some more. So let me know. We'll keep in touch. All right, Captain, you have my email. Sounds good. We'll be in touch. And that's it. And now that way, people with limited access to overdose education can get it. And also those uniformed personnel that perhaps are not considered first responders, but they're first on scene.
Yeah.
These are there. And I honor that because I'm doing what y'all do. I'm in prevention and education and harm reduction. But as a entity representing the Office of Public Health, it's important to me to do that outreach. So I have kind of like minimized that hesitancy that they have had into like, I don't want to carry Narcan in, like, or like, I don't carry insulin and all that. Good thing I haven't heard that so far, but I have clarified because they have emailed me and said, none of my guys want to use it if it's something that we have to inject or some syringe related. And then we just say, look, it's easier now, nasal spray. And then like, okay, sounds good, give me 30. So
I love
yep.
it.
Right,
That
right.
is the way it's done, Jose. That's amazing.
Yeah, we keep moving. We gotta keep moving for small towns.
Love it.
Jose,
And
it's amazing what it is that you offered, and I applaud you, Jose for president, y'all.
No.
Man, you're
I'm writing him in as a writing candidate. Here's the thing. I would say, one of the biggest things that you just shared, Jose, that I think is really, really pertinent for everyone, is the fact that there's education that is still really, really, really important to happen. And sometimes the reluctance doesn't have anything to do with a bias that people might have. Sometimes it's simply because they just don't know what they don't know.
Right.
It's a lack of understanding. And when you're able to meet those folks where they are and be able to help them with the understanding of how to go about administering safe, proven techniques and resources that are life-saving, then you bring more folks as allies into this. And so that's also a way of minimizing and mitigating the stigma that Dorothy's talking about. Great example, Jose. Thank you so much for what you do.
Thanks for organizing this. This is great, and I'm happy to be able to share because sometimes when you're just here in the office space, you're like, what am I really doing? But then share what I'm doing, and then I'm like, oh, that's me really. Okay, well, great.
love that.
Just put things in perspective with other professionals.
I love that. I love that.
Absolutely.
Thank you, Dan. That's amazing.
Thank you.
And so stigma really is the elephant in the room, and it can be because of lack of education or lack of awareness, or it can also be really linked to power and social constructs, right? Like those people over there, with all of that judgment. But the other thing that stigma does too is it also really is impacting people who are using, because stigma makes them feel less than, feel isolated, and think about our language. dirty needle. Like, stigma also impacts the person to make them feel not worthy and frankly not human in many cases. Charlotte says, educating our community partners is key when it comes to harm reduction. Hear, hear. If they don't understand, they may never move to use the tools, yes, that are provided to them. All of our deputies, police, fire departments carry Narcan. And IMCAL Community Services provides the training. Beautiful, beautiful. Love it, love it. Here's some misconceptions about harm reduction and how stigma is providing, and I'd be interested to hear if any of you have heard these in your work, or what else you've heard is that providing syringes and naloxone actually will encourage drug use. Providing syringes and naloxone may tempt people to start using because now there's a safe way to get out of it. I mean, this is one, and I've done a lot of work over the last couple of years in working with communities to address the lack of access to medications for opioid use disorder. And even in the medical community, I still see this. And with families of people who have an opioid use disorder, that it's trading one drug for another to use medications for opioid use disorder. And the science and the research doesn't bear that out, but that's a real misconception that's really rooted in stigma. And that harm reduction strategies are anti-recovery or anti-abstinence. And they're not. They're strategies to help people be safe where they are right now, period. Mike says, yes, I experienced each of these over time. And yeah, any other misconceptions that you can think of related to harm reduction and stigma? That trading one drug for another for MLUD is one that I've heard. I still really, really hear it surprisingly often.
Yeah, I would say in years past, it was looked down upon to offer methadone treatment for people who experienced opioid addictions. And in fact, they still are having to open up buildings that are within the community, but disguised, if you will, so that it doesn't look like a treatment facility. That still goes on, and it's difficult for the patients. That's why the hours, partly because of employment, but that's why the hours are so early in the morning and close early in the afternoon, is to help them with employment, but it's also to, if you will, cut down on traffic during the day to sort of conceal the identity.
Yeah. Thank you for sharing that, Mike. It's still very much, when we look at medications, there still is stigma that really impacts the hours or where the location of methadone clinics may be, or, it also may impact physicians who are willing to prescribe Suboxone, for example, in primary care. We've heard many times that, medical clinics don't want those kind of people in their office, but the reality is not everybody is in that spectrum of chaotic use. There's a lot of folks that have a substance use disorder that are working and are gainfully employed and are going to the doctor's office anyway, but stigma makes us think like we don't want those people. Well, those people are us. We're already in the office. So we already talked about food. What are some other misconceptions about harm reduction that are rooted in stigma? One that I can think of too, and I'd love to hear something in the chat box, is I would say also recognizing that substance use disorders are a brain disease versus a choice. And I think we still see that many people, individuals, really still view substance use as a choice. And it's not a choice. And like we said at the very beginning, is sometimes substance use is not because people, want to enjoy or party, but they're trying to stave off withdrawal and sickness. So it's absolutely not a choice. Plus the brain chemistry changes. It's not a choice.
Dorothy, I'd also share that I think the faith community can really, really be a huge, huge, huge ally in helping to support of the recovery of those that are and have been using or were using or are using, and the promotion of the positive aspects of harm reduction and appropriate and sensible and science-based harm reduction
Yeah.
strategies, really helping and can go a long way with helping support the minimizing and the mitigating of stigma, because there's a lot of stigma that is often associated in our houses of worship around substance use and misuse, that can be, turned towards really helping folks get to better public and behavioral health.
I love that. And one of the things that brilliant, Carlton, one of the things too that in terms of the faith-based community is very often the faith-based community supports recovery groups or peer support groups. And we still see that how does stigma impact that? That if somebody is on is taking medications for opioid use disorder, they may not be considered by that particular group based on their philosophies to be in recovery. So sometimes we see folks that are moving toward recovery and using medications, not being able to find those community-based supports because of the misconceptions and the stigma related to trading one drug for another. So regardless of where we work on the continuum, and the vast majority of us are preventionists, can we as prevention providers help combat and dispel some of that stigma? How do we do that? I'd love to hear, what are some practical steps? And I can think of like about 10. What are some practical steps that we can take as prevention providers?
I'll offer it. Please put it in the chat or raise your hand and please share. We'd love for you to come off mute. Thanks for all those who have done so already. I'll start off the conversation, Dorothy, and simply say that for me, I remember when a great mentor of mine, Dr. Robert DuPont, Dr. Bob DuPont. Dr. Bob DuPont was the second drug czar in the nation, and I'll never forget a time when he came to me and he shared with me. He said, "Have you been to any AA meetings or any NA meetings?" And at the time I had never, and I was even curious as to why he was asking and suggesting such, and and simply as a result, he said because he's learned so much around and about the work we do in prevention from working with those and speaking with those and hearing from those and learning from those with lived experiences that are going through the great work of recovery. And it changed everything about the way I approach the work that we do, and helping to mitigate. I began going to some meetings and began just listening and learning and being grateful for the welcoming and being transparent with respect to my relationship and my own participation there. But that was extraordinary for me as a non-user, and as someone who's been focused on prevention for as long as I've been focused on prevention. It radically changed the way I approach the work that we do, and really helped to disarm stigma that I didn't even realize that I had in the employment of the work that I did.
The thing about taking, I love that, Carlton, and brilliant. And that's really the overarching theme of this whole harm reduction discussion for those of us working in prevention is sometimes we've got misconceptions or beliefs or attitudes that we don't even recognize that we have as humans and preventionists. Love that. One other way that I can think, and I'm please, we'd love to hear from you, is thinking about terminology. Are we using, do we have the term abuse in our written materials, or do we use? Have we done a language audit of the materials that we have? Shelley said, be committed to learning and developing the ability. Oh my God. Yes. Self-check.
Love that.
Love that. That's what I've been trying to, that's it. You just coined what, yeah, check. Let's self-check. What are our attitudes and beliefs? And are they being reflected, onto our communities based on our actions or inactions? Love that. I also love, Charlotte, you talked about real tangible steps when you're talking about education about what harm reduction is, as well as what harm reduction is not. It is not encouraging drug use. It is not encouraging the initiation of drug use, because now there's fentanyl test strips, what it is and what it's not, and looking at our own misconceptions. So Jose said, I often send this resource from the NIDA to those who could benefit from. Yes, I thank you. Mike says, we have to take the time to examine and challenge our own. That's it. That's why I said at the beginning of this that it was a journey. It was a journey for me. And we need to challenge our own beliefs regularly. Yes. And for those of us that are working in prevention, we don't, for those of us that aren't working, in treatment and recovery routinely, we still need to understand sort of that whole experience and what it is that, how we can inform that work. And, stigma creates barriers for people. And so not only are attitudes and beliefs important for us to inform their work, but as citizens and community members, it's important for us to recognize that if we don't actively combat stigma, it's going to cost somebody their life, because stigma is preventing evidence-based public health practices from occurring. And we want to try to do whatever we can to sort of remove that judgment, whether or not we are the ones that are providing the services, but are we really actively moving towards reducing stigma? And this is the last piece that I want to just share. And I'm going to give you a minute to look at this, because I was looking at the tree again this morning. And this came from a website called harmreduction.org. And I love this. It wraps everything up beautifully. Over here, here's sort of where stigma lies. And for harm reduction, with stigma, we think about the drug user is not trustworthy, they're lazy, they're sick. And so that's our root sort of foundational perceptions, which then informs the belief, oh, well, we can't trust that drug user. They don't have the willpower to stop. Oh, they can't help themselves. They're completely out of control. And how does that inform our actions? Well, we ignore the person and we just say, here's what needs to happen for you. Or we require something because otherwise they're not going to do it. Or we only talk about the disease and their problems as opposed to what they do have control over. And everybody still has good things in their lives, even if they're active substance use disorders, but we focus only on that addiction, on that disease. Versus if we do, as Mike said, and take the time to examine and challenge our own beliefs regularly, we can move to a point where we think about people as people that are capable and trustworthy and caring. And it's going to help us sort of change our beliefs from they're probably lying and they don't have control to, yeah, they can do this. And they are telling the truth, or they're trying to tell the truth, or they're working to tell the truth. And they care about their community. And then that can lead to actions that really help liberate people from the impact of stigma. So things like working together with people that are in active use to create plans based on where they are and what they need. And that we understand that clarifying story. And I love this when we think about trauma, instead of saying, what's wrong with you? What happened to you? Tell us your story, tell us. And Dale, that also I think about at the heart of this is that equity piece, is understanding those sort of underlying factors and understanding a person's story, as opposed to stigmatizing people and just looking at sort of where they are in their substance use. And so I love this tree of liberation because it can help inform our own work, but it can also help inform us as individuals and our own beliefs.
Yeah.
So with that, I have one last question, and I'm going to ask everyone to either unmute or to put in the chat box, just like you were asked to put your name in. What is one action that you can or will take as the result of today's conversation? And it could be I'm going to talk to my husband over dinner about stigma or harm reduction. What's one action you're going to take, Carlton?
I love what you shared about stigma, and I'm going to take that and share that everywhere. You said stigma is preventing evidence-based public health, life-saving practices from occurring and being effective. My emphasis, but that was brilliant. I'm going to share that everywhere I go. Thank you for your brilliance, Dorothy Chaney.
Well, that sure made me feel good. Thank you, Carlton. Donna says more understanding and compassion. Tamara said meeting people where they are. Yes, meeting people where they are. We can stop looking at what a person looks like on the surface because we don't know their story. Yes, of how they got here and what we're doing. Yes, share the information with your coalition. This would be a great coalition discussion. Oh my goodness. Continue to learn the proper language. I love that. Lolita, I will share. I lost you. The people I know about stigmatism of substance use, talk with someone in recovery and listen to their story. Dale, yes, I'm going to meditate and think about reducing stigma when doing mindfulness training. Oh, no, that's amazing for myself and when sharing skills with other coworkers and outreach teams. Amazing. Thank you so much, folks, for going on this journey of harm reduction with me today. I'm going to stop sharing. And thank you for the time and the energy that you put into this session. And thank you again for sharing your thoughts and your comments. With that, I'm going to turn it over to you, my friend Carlton.
Thank you so much, Dorothy. And everyone, if you don't mind, those of you who are able to come on camera, please come on camera in this last little bit. And also, if you wouldn't mind using your impressions or expressions, please give Dorothy a hand clap or a thumbs up, or let her know just how much we appreciate the great presentation that she offered. Thank you so very, very much, Dorothy. Really appreciate that. I am excellent, Jose. Thank you so much. Absolutely. I just put in the chat. A link for the evaluation for this particular training. I'm also going to offer that here as a QR code. So if you guys can see this, go ahead. I put the link also in the chat, but if you want to go, oh, why did I do that? Now I have to go through the whole things. I had it all set up for you guys. I had it all set up.
You did, Carlton. You was right there.
I was right there. Here, guys. Here it is again. Please use the QR code and go to the evaluation. We are so very, very grateful to LCPR, to the great team there at the state who have led us and helped us to be able to have these conversations. Thank you all for your leadership. We are looking forward to the next time we all come together and we'll be able to do a deeper dive into the social determinants of health and a deeper dive into the application of the social determinants of health and race and how that works for you all. We're looking forward to that conversation as well. There are going to be some other trainings that you're going to be introduced to as well, and I'm going to share that and turn the microphone back over to Paula in these last moments. Thank you all. You all are heroes to me. Heroes. Thank you for who you are and who you choose to be.
Thank you, Carlton. Thank you, Dorothy. Carlton, can you close this so I can see everybody?
Oh, yeah. If you want me to
Yeah, that's perfect.
take that shot. We need those evaluations.
Yes. Please do the evaluation. That will be so important for us to continue to provide these trainings to you. Thank you, Carlton, again. Thank you, Dorothy. Great presentation. As you guys know from the email, this is a series. So this was our second series. So we're gonna offer you guys the third one. So make sure that you register as soon as you receive the link. Go to the website, go to the LCPR website. We have all these trainings available. We have Dave Clausen will be on February 21st. Yeah, and the registration is a series as well. The registration for the 3 series are available already. We bring in Katka. We bring in Katka for those who were not they couldn't go to the conference. We bring in Katka to Louisiana. So the links for that are available. The registration is open. We're gonna do one in Baton Rouge and we're gonna bring one to New Orleans. Thank you, Ed, for helping us with the location and helping us with the registration. Ed has been very, very helpful to help the LCPR bring this one to New Orleans. So again, thank you guys for being here. Be safe. It's Mardi Gras. Okay, we're getting ready for the parades and the time off. So we're gonna be party responsibly in Louisiana because that's what we do. We prevention people. So be safe. And if you guys have any questions, please feel free to contact me. Dr. Tolbert and I and the whole LCPR team is here for you. Thank you to the state. Thank you, Felicia. Thank you, Leslie, for supporting the center to providing these trainings to all of you guys. This is great. And you guys doing a great job on the field. So let's keep doing this. And don't forget to put your name on the chat so Carlton and I can work on the certificates because sometimes it's hard when you don't sign in. Okay, so, and we're gonna try our best to give you these as fast as we can, but we need your help. Thank you.
Once you get for the evaluations, we'll also have a recording for you. Dr. Leslie, it's great to see you. Dr. Tolbert, I know I saw her somewhere around here. Dr. Harrison, Dr. Brohow, thank you all. God bless you all. Thank you so much. Dorothy, thank you for everything that you've
Yeah.
done. Appreciate you, my friend.
This was
Thank you,
great
Dorothy.
though. Carlton, as I was listening today, I'm
Yes,
like,
ma'am.
we spent so much time in prevention trying to be credible. And we spent so much time in prevention so that people understand that prevention is a science and that it's based in knowledge, it's based in data, it's based in outcomes. And I guess as I was sitting here today, it almost feels like harm reduction is where prevention was at one point.
Yeah.
And so, but if we are truly preventionists, we know how to use data to make decisions. And if we look at the research about harm reduction, it is a best practice. It is something that can improve outcomes, that can improve people's lives. So I felt it a different way today. It's for us to speak the truth about harm reduction as preventionists. We understand what our role is, but it's our job too to speak the truth about what harm reduction is and that it is beneficial and it can help save lives and it can, I don't know, I don't know, maybe had some kind of epiphany, but I was thinking about like, we used to say, well, Nancy Reagan said, just say no, or this is your brain on drugs, and that it was supposed to deter people. And what we learned from that is like, it's not enough. That alone is not enough. You have to be able to, you have to help people build skills you have to be able to have someone that understands how to refuse or coping skills, or I mean, just all this stuff. And I was like, wow, we had to do that. We had to go through that process so that we could articulate it to others. And I just feel like it's almost like harm reduction is in that same place. It's not just say no. But we have to be able to meet people where they are, to acknowledge that one size does not fit all. It never has. One size has never fit all. I don't know, like I had a moment.
That's a,
But it was
that's a beautiful.
but it really spoke to me because, I've been one that probably, I'm a purist,
Yeah.
primary
Come
preventionist.
on. Yeah,
But, I don't know, I was just hearing like, it's our job to speak the truth about this. That's what we're supposed to do.
too many lives are at stake. Too many lives matter. You're exactly right, Leslie. And I don't think anyone could have said it better. That was extraordinary. That is what
I
we
kept
refer
putting
to,
it in the
Dorothy.
chat and then taking it out and putting it back in and taking, and I was like, because I didn't really know how to articulate it, but I think it spoke to me a different way today. Like I heard it a different way and I'm thinking, yeah, like it is our job to speak it.
Thank you.
Thank you, Leslie. That was great. You know, I think hearing from the leadership, like your feedback, I think it's so important because I think it spreads, you know, across the field. Because sometimes, and that's what is kind of like scary, like we offer the trainings, we offer these opportunities, and we really want, like we get all excited because we really want people to get something out of this. And it's not just like, oh, one more training or one more thing, you know, oh, let's put one more on the schedule. No, let's do something that makes a difference. And hear from the people that are receiving, I think it makes all us happy and want to do more and want to do more. Yeah, thank you.
Yeah.
Thank you all very, very much, Leslie. That was what we refer to as a mic drop moment.
Yes,
That-
yes.
that-
There you have it.
That's what
I have them every few years. I might have a mic drop moment.
If you weren't sure, that's what just happened. That's what just
All right.
Yes, yes, indeed. Okay,
Thanks.
Carlton, Dorothy, we're gonna stay online for a few minutes to wrap up.
Absolutely.
Okay, thank you.
Bye-bye.
Take
Bye.
care.
Again.
Thank you, everyone. Thank you. Thank you, Leslie. Thank you, Jose. Thank you,
Thank
everyone.
you,
Thank you, Crystal.
everybody.
Bye.
Absolutely.
Bye.